Welcome to Part 4 of Care of the High-Risk Newborn. This video lecture is going to address the respiratory issues. The more premature a baby is at the time of delivery, the higher the risk of them developing respiratory distress syndrome. We abbreviate it RDS. In the past, we called it hyaline membrane disease. What happens is, as a result of prematurity, the neonate does not have adequate surfactant that's needed to exert pressure on the alveoli to maintain them in an open position. As a result, the alveoli collapse and there is little to no exchange of oxygen and CO2. So what is this going to look like on your patient? Well, certainly they're going to have respiratory distress, and if we don't act quickly enough, it's going to lead to respiratory failure. So this baby will be tachypnic. Remember that a normal newborn has a respiratory rate of between 30 and 60. So now this baby is breathing up at 70 and 80, and I'll tell you that's really difficult to be able to count that. They're going to exhibit retractions and nasal flaring. When you put them on a pulse ox, it's going to be decreased, and they're going to show cyanosis. Eventually, this baby is going to be tired of breathing, and they're going to end up with apnea and bradycardia. This graph displays what the likelihood is of a baby developing RDS based on their gestational age. So you can see those early babies, 24 weeks, 26 weeks, they're close to 90 to 100% risk of developing RDS. What's not on this graph are the babies that are born between 20 and 24 weeks. They're going to be very close to 100% because they're going to end up being on a ventilator. They're too little to be able to breathe for very long on their own. They're going to get too tired. The closer we get to term, less the chance of having RDS. But it's not zero. You notice that at 34, 35, 36 weeks, we're still looking at about a 25 to 30% risk of a baby developing RDS. So how do we manage it? Well, first of all, we don't let those obstetricians deliver these babies unless they absolutely need to be delivered prior to 39 weeks of gestation. And we're going to talk a lot about that in Nursing 174. So once the baby is here and they do have RDS, we can administer surfactant via the ET tube. But the neonatologist, they had the decision of, does this baby need to be ventilated, or can we just give them a high-flow nasal cannula? Can we give them CPAP? Well, if the baby absolutely needs to have surfactant, they have to be intubated. So we're going to support their oxygenation and their ventilation by administering oxygen. The baby, like I said, they might be put on CPAP. They may be put on the standard mechanical ventilator that can give them a respiratory rate of about 60, maybe even a little bit higher. Or they'll put them on a high-frequency ventilator or an oscillator, and that can deliver up to 3,000 breaths per minute. Now, very few babies need to be that high, but it's not uncommon for them to be getting at least 300 breaths per minute. It almost looks, the baby ends up shaking the whole time that they're on this oscillator, and it almost looks and sounds as though they're being percussed, but they aren't. But the beauty of these oscillators is not only does it give them the rapid respirations, it also teaches a baby how to breathe on their own, and it promotes growth of the smaller airways. And believe it or not, even though it looks like it would be more violent, a high flow or a high frequency ventilator or oscillator is gentler than the conventional mechanical ventilators. Some babies may need nitric oxide, and others may actually have to go on an ECMO machine, and that's for the really severe RDS. We can minimize this baby's demands for oxygen just by leaving them alone. So we really want to chunk our care Only touch and stimulate this baby when you absolutely need to. So if we're going to give meds or we're going to give a feeding, then we're going to do vital signs and diaper change and feeding and meds all at one time, and then stay away from the baby and keep the noise to a minimum. Here's a cute little guy who's on a nasal CPAP. So this is little Jackson. Just eyeballing him, he looks like he's about 35 weeks. He's got plenty of subcutaneous tissue. He's got nice little chubby cheeks. But you can see that, obviously, he was not breathing well on his own. And here he is again. He's got an umbilical catheter. He's under Billy lights, and he has a nasal CPAP. But look at the outcome. This is the same little baby who now is the representative for baby gap. Here's a picture of what the typical ventilator looks like and what an oscillator looks like. And respiratory care will be taking care of these. And this is a picture of a baby who is on a high-frequency oscillating ventilator. I wish I could put it in motion and you could see them. The downside of them developing respiratory distress syndrome is eventually acquiring bronchopulmonary dysplasia. We're having better outcomes than we did a decade ago because we have better technology, but it isn't gone completely. With this disorder, the epithelial tissue of the alveoli are damaged due to the pressure settings on a ventilator, the high oxygen levels that we need to administer to the baby to maintain an O2 sat above 90%, and it may also be from any kind of a respiratory infection that the baby may have acquired. As a result, the epithelium becomes very thick and parts of it become necrotic, and then it gets scarred. So bronchopulmonary dysplasia is now termed chronic lung disease. So they have respiratory distress. They're going to be difficult to wean off of oxygen, and so they're going to go home on oxygen. They have a high incidence of recurring respiratory infections, be it viral or bacterial. They end up with some form of a reactive airway disease that requires medication, and many of them end up having pulmonary hypertension. Because they're working so hard to breathe, they have failure to thrive. In addition, they may have other chronic conditions like gastroesophageal reflux that increases the risk of aspiration, and this is going to contribute to chronic lung problems. And this is a picture of what BPD looks like on an X-ray. And notice that it's whited out so much that you can not make out the silhouette of the heart. Normally you should be able to see beautiful dark lungs where the airspace is, and then that heart sitting right there in the center of the chest. But you can't see it on this one. When a child has chronic lung disease, we need to administer oxygen. And we're going to gradually wean them down. And some of these kids, they're only on a 0.25 liter per minute, but we can't get them down to 0. We're going to do percussion and postural drainage, and we're going to teach the parents how to do this. When they get old enough, they can get one of those vests, but until that time, then we have to do it manually. They're going to need suctioning and positioning. Some of these kids end up going home on a trach. Some of them may be on BiPAP or CPAP and home ventilators. And if they're on a home ventilator, that means we need to have a home health nurse in the facility, in their home, to help the parents. Medication-wise, if they have pulmonary congestion, then they can be on diuretics such as Lasix. They'll be on albuterol as their bronchodilator, and then they can go on caffeine. And caffeine helps enhance the compliance of the lung itself and relax the smooth muscle so that the lungs facilitate the breathing mechanism better. If the child has an infection, then we'll give antibiotics for any kind of bacterial type infection. And these kids are going to, if they're preterm, they are going to be good candidates for the Synagis vaccine so that they don't develop RSV. We'll monitor their fluid and electrolyte balance, make sure that nutritionally we're going to give them support. If they tire with feeding, we're going to give them that higher calorie formula. And then provide developmental support. Support for the family is needed, including teaching them CPR, how to administer meds, how to do percussion and drainage, how to suction, how to take care of the trach, including changing the trach ties. And believe it or not, they become masters at doing this. They'll teach you a few things. And here's a little guy who has chronic lung disease. So he still needs to have a walker, but that's okay. He's standing up, he's on a ventilator, and he's looking like he's gained quite a bit of weight. Look at those cheeks. And this ends the section on respiratory disorders in the newborn.